Hey everybody, and welcome back to the Heartbeat Debrief. I'm your host, Evan, and for those of you that are new here, this is the podcast for healthcare workers and all of the things that they take home with them. The doubts, the dark humor, and the things that don't make it into our charts. Now, today's episode has been sitting in my notes app for quite a bit of time, and that's EMS versus nursing. And now I'm not talking about which one is better. Okay, I'm not talking about which one is more difficult or which one has more trauma stories, but kind of what both sides of those careers kind of look like and my journey between the two.
The views and opinions expressed in Heartbeat Debrief are solely those of the host and guests. They do not represent the views of any employer or organization. This podcast is for educational, mentorship, and guidance purposes only. If protocols or policies are discussed, always follow your local or state organizational policies and procedures, regulatory guidelines, and scope of practice.
Now, many of you know that I worked pre-hospital before transitioning into the NICU. I went from these really uncontrolled environments to highly controlled ones. I went from diesel engines and radio reports to ventilators and IV pumps. I went from these 20-minute patient encounters to week-long arcs of care. And I thought that the medicine would be the biggest shift. And I kind of touched on this in a previous episode, but the medicine wasn't the biggest shift for me. It was the emotional aspect of it and the identity shift. So today we're breaking this episode down into layers: identity, autonomy, time, emotional weight, clinical depth, and really everything in between. And if you've ever transitioned specialties or you're thinking about it, then this episode may be for you. So when we talk about identity, EMS has a very clear identity. You show up, you fix, you move on, you hand off, and you clear. Okay, there's something very addictive about that rhythm. It's kinetic medicine. It's action-oriented. You get that immediate feedback because you are the intervention that patient needs. But suddenly, everything in your life revolves around EMS. And I'm very guilty of this. Your car has something identifying you as EMS. You've got off-duty swag from all 3 to 4 services that you work at because, let's face it, you work in EMS. You have 3 to 4 jobs. And your social media somehow becomes 98% shift humor, or it's EMS social media influence, TikTokers, and it's all about EMS. And then everyone around you knows that you're an EMS. And for a while, that's okay. That's the cool thing. We're proud, and we should be, because it is a very difficult job. It takes grit and decisiveness. It takes a very certain personality to work in EMS. But after a while, something kind of shifts. The stories aren't as shocking anymore. And the chaos really doesn't give you that adrenaline spike that you used to get. You start becoming numb to the things that used to rattle you. And interestingly enough, you don't always want people to know that you're in EMS anymore. Am I right? It stops being a flex and it becomes something quieter, more personal. And when I walked into nursing, my whole attitude kind of shifted. Now, I still collect stickers. I'm proud to be a nurse. People around me know that I'm a nurse. That part of me has not changed. But it's not my identity. And I think it's because I realized that in EMS, we show up, we stabilize, we leave, and we keep going. But in nursing, you don't get to leave. You have to sit in the aftermath and you manage drips and vents and you trend lab values and you adjust and you're constantly reassessing. And then you repeat. Okay, you're not just the arrival for that patient anymore or the first 20 minutes of their problem. You are that continuous presence. And there's a psychological term for what happens, I'll say, in EMS, but I'll also say that if you're brand new to nursing, you could also experience this as well. And that's identity fusion. And identity fusion is when your personal identity and your group identity become tightly bonded. It's stronger than just belonging to a team. It's when the job doesn't just describe what you do, it describes who you are. And I feel like all of us in EMS can relate to that because EMS is, I would say, designed to create that feeling. We wear the uniform, we speak the language, we all share that dark humor that only your coworkers understand. And you go through these high adrenaline events together, and that shared stress accelerates that bonding between each of you. And if you don't want to believe me, that's fine. There's the neuroscience out there to back this up. But when people experience stress and danger together, it strengthens the social cohesion through these hormonal responses such as oxytocin and adrenaline. And those responses pair with that stressful or traumatic memory, and that's why these bonds feel so intense. That's why it feels so meaningful. And that's why for a while, EMS is everything to you. But what you're not seeing is the habituation that comes with it. And habituation is when repeated exposure to that same stimulus reduces your emotional response to it. That first code that you run, electrifying. But the 15th feels different. You feel fine or unremarkable. Okay, your nervous system has adapted to it. And honestly, it has to, because if your nervous system didn't, you would burn out instantly. But that adaptation comes with a side effect. And it's that things that once felt dramatic become routine. Things that used to shock you barely move your adrenaline needle whatsoever. And that's kind of where people start to become numb. And they don't become numb because they're broken or they're cold. It's just that they've adapted. Okay, our brain, friends, is very efficient. It normalizes what we see repeatedly. But when your identity is fused with these high adrenaline environments and your nervous system starts adapting, you can almost feel like you're losing something. But you're not, okay? You're just evolving. And when I walked into nursing, instead of my identity being built on intensity, it was built on consistency. And nursing, I'll say this with a grain of salt, nursing doesn't rely on adrenaline bonding the same way as EMS. Now, that's not to say that I haven't had trauma bonds in the ER or in the ICU, but nursing relies on sustained responsibility. Okay, you're building attachment not through chaos, but by proximity, through repetition, by sitting with families and patients and being present when nothing dramatic is happening. And psychologically speaking, that's a different type of identity formation. It's less fused and it's more integrated. Now, in EMS, I can feel like it's kind of like a tribe, whereas nursing feels more like a profession. Not saying that EMS is not a profession, because it is. But when I transitioned, I didn't lose my EMS identity. I just reorganized it. And that's why the shift, for those of you that are going through this, can feel very destabilizing at first. You're not just learning new skills, you're rewiring how you see yourself. And that's a deeper change than most people probably expect. It definitely was a more deeper change than I had expected. Next, I want to talk about autonomy. In EMS, you feel very autonomous. You are in the back of the truck, you're making calls, you're following protocols, you're thinking on your feet. You are in control. Okay, EMS makes you feel very independent, and I loved that about EMS. But as a nurse, when I stepped into a hospital system, and now I have providers, charge nurses, respiratory therapy, pharmacy, and then you add in policies, committees, documentation, standards, metrics, all of that at first can make you feel like your independence is gone, out the window. And I will say that I felt that exact same way. I was like, wow, this is a mother may I system. But what kind of surprised me is that EMS autonomy is rapid decision-making within a narrow time frame, whereas nursing autonomy is influenced within a very complex system. And that difference is a different kind of power. Instead of asking, what do I push right now? You start asking what the trajectory of this patient is and how do I intervene early? Okay, it's less dramatic and it's more strategic. And honestly, I think that requires a very different type of confidence, because in EMS, if I'm unsure, I can phone a friend, I can call medical control, I can give a phone report, I can ask directly for orders and guidance. The interaction is very focused, it's concise, and it's built into the EMS workflow. But in nursing, I don't just call the doctor, okay? I have to assess, I have to trend, I gather my labs, I anticipate what the provider is going to ask before they ask me, and then I communicate all of that. And how I communicate that matters. I don't just say, hey, what should we do? I have to say, here's the situation, here's what I'm seeing, here's what's changed, here's what I've done, here's what I'm concerned about, and here's what I recommend. Okay, it's taught to every single nursing student, SBAR. And that shift, when I learned that shift in nursing school and got to the bedside, it really humbled me because now I'm not just reporting, right? I'm being an advocate. I'm advocating for my patient. And I have to learn what questions to ask, and I have to learn who to ask them to. And with that, I almost have to learn how to navigate personalities and timing and priorities. Okay, it doesn't mean that you have less autonomy as a nurse. It means that your autonomy lives inside of a very complex system, and it's layered and it's relational. Whereas EMS, that autonomy is very fast, direct, immediate. And learning that difference, learning how to speak up strategically instead of urgently, that has taken me some time to learn. And I still catch myself from time to time learning how to speak strategically, because learning how to speak strategically versus urgently almost comes from education. And that's probably another big difference between EMS and nursing that we don't talk about enough, and that's our education that we get. Now, this is probably going to ruffle some feathers, but I feel like it's a very important conversation that we have because paramedicine in most places is still primarily a certificate program, right? You can complete it in a year to 18 months, sometimes less. If you're in the military, probably 4 months. But nursing at a minimum is an associate's degree. Many hospitals now are requiring, or they are strongly encouraging, a bachelor's degree. But there's a very clear academic ladder. CNA, LPN, ADN, BSN, MSN, DNP, PhD, right? There's research, there's policy involvement, there's academic leadership, there's a structured personal development plan. EMS doesn't have that. And if you are lucky enough to work in a system that does have that as an EMS provider, kudos to you. But the uncomfortable truth that a lot of my colleagues in EMS probably don't want to hear is that if EMS wants the same professional recognition and autonomy, compensation, and policy influence that nursing has, our education has to evolve. And this isn't about whether paramedics are smart enough. They absolutely are. Okay, I have worked with some of the sharpest clinicians in medicine in the back of an ambulance. This is more about academic standardization and professional leverage. Okay, everyone knows that nursing fought so hard to be seen as a profession rather than a technical trade. It moved from hospital-based diploma programs to degree programs. It embedded research, it built governing boards, it established national accreditation standards. And then it went on to develop graduate pathways. All right, education gave nursing power. Not ego, not status, but power. And power in rooms where decisions are made. EMS is still largely protocol-driven and medically directed, while nursing is more collaborative and has independent licensure and its growing policy voice. And that difference matters. But I think what the deeper issue is when your minimum entry requirement into this job is a certificate, it limits upward mobility. Structurally, it limits the research production. It limits reimbursement leverage. It limits the political influence that we have. And like I said, right now, paramedicine in many regions is a certificate program, and it's operating on a model that has not significantly evolved in decades. But healthcare has evolved. Critical care has evolved. Pharmacology has evolved. Our overall systems thinking has evolved. But the educational model behind EMS is stuck in the Stone Ages, friends. So if EMS wants to have an expanded scope, increased pay, increased autonomy, and be viewed as healthcare providers rather than transport technicians, or as some people refer to us as ambulance drivers, or we want to influence policy at state and national levels, then at a minimum, paramedicine needs to move towards an associate degree standard, if not a bachelor degree standard. Okay, other countries require their paramedics to hold bachelor's degree, and I think that we should follow suit. I have worked with paramedics from Canada, Germany, New Zealand, and all of them hold bachelor's degrees. And I'm not saying that we need to follow suit because I don't think our current paramedics aren't capable, but because professions gain leverage through academic infrastructure. And the interesting thing to think about is that when you raise educational standards, you're also changing the culture. You're introducing more emphasis on research literacy, and you're building stronger foundations. Okay, and these stronger foundations in pathophysiology, or you're increasing exposure to public health concepts, you're creating these pathways into advanced practice such as critical care or flight or community paramedicine. And it stops just being about the calls and it becomes about the system. Now, I want to be fair because there are some barriers to this, right? Cost, access, rural staffing shortages, volunteer services, funding. We can't just flip a switch and demand degrees without restructuring the entire EMS funding model. It would be absolutely reckless. But if our profession wants long-term growth, then the conversation has to start somewhere. And I know the conversation is happening in many places. I've seen it on Facebook and LinkedIn, and I think that's great. And these people are having these conversations because they realize that nursing didn't transform overnight. It pushed and organized and it demanded more, and education was the backbone of that transformation. So if EMS wants to be at that table, then education has to be a part of our strategy. Now, I'm not trying to cause a division between EMS and nursing. I'm just asking what kind of future pre-hospital medicine wants. Do we stay a trade, or do we want to evolve into a fully academic, research-driven healthcare profession? That's the real question. Now, with all that being said, before anyone starts typing angry messages or posting mean things in the comments, let's talk about the other side, because this issue isn't just black and white. The first counterpoint that I talk about is that raising education standards does not automatically make better clinicians, and a degree does not guarantee critical thinking. Okay, it does not guarantee that the practitioner is going to remain calm under pressure. It doesn't guarantee compassion. Okay, some of the most clinically sharp paramedics that I have ever worked with came from certificate programs and can outthink half of the room in any given crisis. Okay, experience does matter. Mentorship matters, and that exposure matters. There's something about thousands of patient encounters that no classroom is ever going to replicate. So this conversation can't become elitist because education level is not a measure of intelligence or skill, but it is important. And my second counterpoint is access. Okay, if you suddenly require an associate's degree nationwide or a bachelor's degree nationwide, what happens to rural EMS systems or volunteer agencies or underfunded counties? All right, our communities are already struggling with staffing, and they're not going to be able to do this. Okay, you are going to unintentionally create a bigger provider shortage than what we already have. You're going to make entry into this profession financially harder for people. And healthcare already has an access problem. We do not want to add to that problem. The third counterpoint is going to be cost versus compensation. Now, here's a bit of an uncomfortable economic reality, but if paramedics are required to obtain degrees, but compensation doesn't rise accordingly, then that's exploitation. And I've seen that in some systems. Okay, we cannot increase educational demands without restructuring reimbursement models and pay scales. All right, nursing's education evolution was paired with compensation growth and hospital-wide expansion. EMS funding is often tied to transport reimbursement or municipal budgets, or even unstable grant funding. That right there is a structural limitation in and of itself. The next counterpoint is going to be the culture of EMS. Okay, we value practicality. It's very hands-on, operational, field-driven. And I think there's a legitimate fear out there that if we over-academize EMS, we could dilute what makes it effective: the decisiveness, the adaptability, the grit. And that fear is not stupid, okay? Some professions out there get buried in theory and they lose their operational sharpness. We in EMS cannot afford that. Our nation cannot afford that. So if education evolves, it must evolve intelligently. More pathophysiology, more pharmacology, more systems thinking. And let's add in research literacy, not just fluff courses. So many nursing programs just have fluff courses. We don't need to add those. And I guess my last counterpoint worth acknowledging is that nursing higher degree standards did not magically eliminate healthcare burnout. They didn't eliminate staffing shortages or system dysfunction, but their advancement in education gave them leverage. But that leverage doesn't fix the broken healthcare economic system that we live in. To my point, if EMS does become degree-based, it will still face systematic challenges, and that's just the reality of it. But if degrees aren't magic and certificates aren't inherently inferior, what is the real issue? And the real issue is the professional infrastructure. It's about creating upward mobility, creating research pipelines, leadership pathways, political representation, creating standardized academic credibility. All right, it's not about making the medic on the truck smarter. It's about making the profession structurally stronger. And those are very different conversations that people need to be having. So if you ask me, in my opinion, if EMS stays certificate-based, it risks remaining operationally essential, but politically peripheral. And if we evolve academically, then it gains a seat at the table where scope and reimbursement and autonomy are all decided. Because the future of pre-hospital medicine isn't just more lights and sirens, friends. It's about integration. And in order to integrate, we need more infrastructure. Now, as we move on, a lot of people want to talk about pay. Well, we can't talk about education and the evolution without talking about compensation, because numbers tell part of every story. And according to the U.S. Bureau of Labor Statistics in 2023, the median annual pay for EMTs and paramedics combined is $39,000 to $40,000, where paramedics alone often average higher depending on their region, but they still have a median of $50,000 to $60,000. Okay, let's go to the other side. The median annual pay for a registered nurse, $86,000. Okay, that's not a small gap, friends. That is like the Grand Canyon. And here's where things get interesting. We all know that both of these roles manage airways, administer high-risk medications, they both make time-sensitive clinical decisions, and both of these roles carry enormous responsibility. So why the difference? I'll tell you. It's not intelligence, it's not grit, it's not dedication, it's not structure. Okay, nursing is embedded inside of hospital systems that bill for acuity, procedures, inpatient care. Okay, that financial model alone supports higher wages. Whereas in EMS, we all know this, EMS reimbursement is, in the majority of the country, primarily tied to transport, not medical complexity, not clinical decision-making, not non-transport treatment. Okay, if the system pays for miles, wages follow miles. And that is an economic design issue, not a talent issue. All of this matters for one big reason, and that's retention. And I know I'm preaching to the choir here because we all know that both sides of these fields have retention problems. But there comes a point where passion meets rent. Okay, when experienced paramedics transition to nursing or fire departments that pay more or advanced practice roles, it's often not that they stopped loving EMS. It's because sustainability has come into play. And it's not about greed. None of us join healthcare for the money. It's about viability. If we want EMS to grow and retain talent and gain professional leverage, compensation has to be a part of this conversation. Not the emotional conversation, but the structural conversation. Because the fact of the matter is that pay reflects how a system values a role. And right now, The structure of EMS speaks loudly about the value in which we hold our EMS practitioners. Now, I want to shift gears a little bit and kind of talk about the difference in time, to say, between EMS and nursing that I've noticed. Time behaves very differently in both of these worlds. In EMS, 10 minutes can feel like an hour. Every second of those 10 minutes has velocity. Every change is amplified. You're managing the worst 10 to 20 minutes of someone's life. And then you do it again and again and again, all in a 12-hour shift. But when you move into nursing and it's still that same 12-hour shift, time isn't as explosive anymore. It's cumulative. You start watching trends and anticipating complications. You're constantly documenting. You're constantly communicating. Okay? Instead of dropping a patient off and mentally resetting, you are carrying this same patient for hours, sometimes the full 12 hours, depending on where you work, sometimes days, sometimes weeks. Okay? And that was probably one of the biggest surprises that I came to cross, was how emotionally different prolonged care of a patient feels. All right, acute chaos burns hot, but chronic responsibility that just weighs on you, that's very heavy, and you don't always notice that weight until you're just flat out exhausted. And when we talk about documentation, that is a culture shock that no one talks about. Okay, EMS charting, we all know, tells a story. How the patient got from point A to point B, what happened, what you did, how the patient responded. And a lot of things in our charts have to be in there for billing purposes, reimbursement, okay? But mostly you're telling a story. Whereas hospital charting defends the story that you just wrote and continues to write the next chapters of it. And honestly, the sheer volume of documentation in nursing is absolutely obnoxious. Okay, it's not just what happened, but it's what you assessed, what you reassessed, what you educated with the patient. Did the patient understand that education? What you anticipated, what you communicated, the care plan that you wrote that nobody looks at, the safety checks that you perform, any other regulatory requirements, okay? You document every phone call you have with every person, every time you talk to the patient, every critical lab result. When you talk to the patient, you're documenting everything pertinent that they said. You chart everything. It's non-stop. There was a recent study that showed that nurses spend 40% of their shift charting. That's almost half of our 12-hour shift. 5 hours to be exact. 5 hours of charting. That's 5 hours spent away from patient care. Or you spend 12 hours getting your ass handed to you, and then you stay late to do all of your charting because you couldn't get to it. All of that excess charting leads to decreased job satisfaction, increased burnout, increased cognitive load, and it leads to less time for self-care, things like eating a snack, taking a break, drinking water, going to the bathroom. Okay, it's tedious and unfortunately necessary, but it's mentally taxing. And in addition to documentation being mentally taxing, I do think that it adds to our clinical depth. And when we look at EMS and nursing and we compare clinical depth to, say, something like clinical breadth, EMS trains you to think wide. Okay, you're building differentials fast and you're scanning environments. You are looking at the mechanism of injury and you're making these decisions with a very limited amount of information that you have in a very limited amount of time. Okay, you don't get lab values, you don't get radiology results, you don't get consults. You can make a phone call, you can phone a friend, but you get a scene, you get a patient, you get a clock. Okay, your brain in EMS is very good at rapid synthesis. Okay, from day one, sick versus not sick, stable, not stable, load and go, stay and play. Those are the things that are constantly going through our brain. And all of that sharpens our pattern recognition in a way that's hard to kind of teach in a classroom. That's why in EMS we are so hands-on. We're constantly doing simulations and we're practicing scene calls in the classrooms with our students. Whereas nursing, especially in the ICU, nursing trains you to think deep. Pathophysiology, lab values, lab trends, medication titration, vent changes. And some of you may be saying, well, I have a pharmacist, I have an RT to do some of these things. Okay, some people don't have all of those ancillary services and they have to learn how to do all of these things. They have to learn how to make vent changes and what those vent changes are going to cause. And hot take, but I think that nurses that know how to do vent changes and manage a vent are better off in the long run. Okay. We also in nursing notice subtle shifts in tone, perfusion, behavior. We pick up on the slightest change in our patient, especially if we've been with them for 3 in a row or 2 weeks now. Okay. The slightest thing we notice. And instead of asking what's happening right now, as a nurse, you start asking, why is this happening and what's going to happen next? You start anticipating. And I thought that I understood disease process when I started in EMS. And I did, but only in snapshots. And then I got to the ICU and I watched those same processes unfold hour by hour, okay? Sepsis at hour 2 looks very different than sepsis at hour 22. All right, a potassium of 3.1 means something very different when you've watched the telemetry strip for the last 6 hours. And the smallest vent change can shift an entire blood gas the entirely wrong way. Okay, that's when my understanding changed from episodic to continuous. EMS gave me these snapshots, but nursing has given me a full-length film. And this is kind of what I find interesting is that the way that each profession trains our brain shapes kind of where you go in life. Let's take EMS, for example. The pathway often looks like EMT, AEMT, paramedic, critical care, flight paramedic, community care, tactical medic, and that's kind of it. There are a few other specialties out there, but there's not very many. But you're operating at this incredibly high level clinically. You start running vents in the aircraft or managing drips during transport. You're making these autonomous decisions in extreme environments. It's very intense and it's focused. It's operationally sharp. But that ladder narrows very quickly towards the top. And on the flip side, when we go to nursing isn't a ladder. It's more like a tree with endless branches. The bedside specialties alone are vast. You have the ICU, the ER, pediatrics, oncology, psych, cath lab. And then from there, you can go into flight nursing, critical care transport, informatics, case management, leadership, education, research, policy. And then from there, you can go into advanced practice, nurse practitioner, CRNA, public health, academia, international work. Okay, the knowledge base is modular, it's transferable. You can go anywhere once you have a nursing degree. And I'm not saying that nursing is better. Okay, it's that their ladder that they have built is like a tree that is growing endless. And the structural difference between a narrow ladder and a tree, that affects longevity. Because, newsflash, our careers have to last us a very long time before we can retire. 25 years is a long time to do one narrow version of a role, okay? That clinical breadth sharpens your instinct. Your clinical depth expands mobility. And when you combine the two of these, you're not just clinically competent, you are systems aware. You understand that pre-hospital snapshot and the inpatient arc, and that integration right there opens doors for people clinically, academically, professionally. So if you're still listening, you made it to the end of this, and you're still asking which one makes a better clinician, nurses or EMS practitioners, if you're asking that question, then you're asking the wrong question. And I say that because that question assumes that the goal is comparison, that question assumes that one of these careers has to win. And it assumes that the value of a clinician is measured by the patch on their sleeve or the badge on their shirt. And that is not how this works. EMS and nursing, they don't create better or worse. The clinicians that they shape is just like training a different muscle group. EMS builds decisiveness. It trains you to move when movement matters. It forces clarity when the room is loud and the clock is unforgiving. But nursing builds endurance. It trains you to stay when things are uncertain. It forces patience when the outcome isn't immediate. All right, one of these careers is sharpening urgency while the other strengthens your presence. And the personal part for me, there were times when I needed the sharp edge of EMS. I needed the movement. I needed to act. But on the flip side, there are times when I needed the steadiness of nursing, okay? I needed to slow down and learn what happens after the sirens stop. Neither one of these careers has made me superior. They've made me very different. And only you can decide which environment aligns with who you are right now. Not who your coworkers expect you to be, not what social media glamorizes, not what looks impressive on a sticker or a badge or in a signature block of an email. You have to decide. Do you feel alive in the first 15 minutes of a crisis? Or do you feel alive in the long arc of a recovery? Do you thrive on rapid stabilization or sustained responsibility? There isn't a universal answer for any of this. There's just alignment within yourself. And guess what? Alignment can change. Okay, careers evolve because people evolve. The career you start with will evolve you. So if you're standing at this crossroad, EMS, nursing, both, neither, doesn't matter. I just want you to know this. The goal is not to pick the better profession. The goal is to choose one that allows you to care deeply, grow honestly, and still recognize yourself at the end of the shift. That is the only real measure and only one that you can make. And something that I've come to realize after standing in both of these worlds is that EMS and nursing are not rivals, despite what anyone thinks. Our nurses do not hate firefighters and paramedics and EMTs. And the firefighter, paramedics, and EMTs, they don't hate nurses. Okay, that is not a thing. They are different phases of the same mission. One catches people when they fall, one carries them through the landing. One lives in motion, one lives in monitoring. Neither one of these is complete without the other. And when I transitioned, I thought that I was leaving something behind. But what I realized is that I was building layers within myself. Okay, I've said it before, EMS has given me this decisiveness. Nursing has given me depth. EMS trained me to walk into chaos, and nursing trained me to sit in that complexity. And the education conversation, that's not about superiority, okay? It's about evolution. Every healthcare profession that has gained autonomy, compensation, leverage, policy influence, and long-term sustainability has invested in academic infrastructure. Not because degrees make people better humans, but because systems respect what they standardize. So if EMS wants a greater scope, stronger reimbursement, a louder policy voice, and long-term professional growth, then the conversation about education cannot be avoided any longer. And all of that being said, that doesn't diminish the incredible clinicians that are working today, okay? If anything, it honors them by asking for more on their behalf, more opportunity, more mobility, more recognition, more power at these decision-making tables. And the real takeaway of this episode is that no matter what letters are after your name, ADN, BSN, paramedic, FPC, CCP, the work is the same at its core. We all step into uncertainty. We manage physiology under pressure. We hold space for people on the worst days of their lives. Different environments, same responsibility. So instead of arguing which profession is tougher and more advanced, maybe the better question is, how do we build healthcare professionals who understand both speed and depth, both chaos and continuity, both action and endurance? Because the future of healthcare isn't siloed, it's integrated and collaborative. It's system-aware and evidence-driven. It's emotionally intelligent. And the clinicians who are going to shape the future are the ones who are willing to evolve, not just individually, but structurally. So if you're in EMS and you're considering nursing, or if you're in nursing and curious about getting into EMS, know that this transition does not erase your foundation. It only expands it. You are not abandoning one identity, you're layering on top of another. So thank you for being here. Thank you for caring about the evolution of this profession, and thank you for continuing to show up. whether it's in the back of a truck or at the bedside. Because at the end of the day, the pulse we protect is human. And that mission doesn't belong to just one discipline. It belongs to all of us. So take care of your patients and take care of yourself. Because in healthcare, you never really clock out.